All right, so in this section of the lecture, I'd like to talk about how researchers have defined and measured pain. So first, I'd like to give you a general definition of pain. So pain is a localized or generalized unpleasant bodily sensation or complex of sensations that causes mild to severe physical discomfort and emotional distress and typically results from bodily disorders such as injury or disease. Right? And really key there is that word typically. We're going to talk a lot about some of the cases in this lecture where pain comes from sources other than bodily injury. And so while that's normally the source of pain, right, we have some kind of cut or damage or wound, burn to our body, or we're sick and there's inflammation due to our immune system trying to fight that, right? So there's usually a source of physical damage that's the reason for pain. But sometimes we have other sources of pain, and so we'll be talking about those as well as physical pain today. Right, and so, as much as pain is a terrible, unpleasant experience, right? It is defined as such. In fact, pain has a really important purpose. Right? The goal of pain is to help to protect us from the world. Right? Pain acts as a signal of danger, of the fact that we're have bodily damage that we need to stop and care for, or that we are about to experience bodily damage. Right? Maybe we've touched something hot, and if we were to leave our hand there, it would burn, and so it is a signal that leads us to pull our hand away quickly. Right? And so pain tells us that there's something wrong that needs to be dealt with. Right? And so similarly, right, if you have extreme pain in your appendix area, that can tell you that there's something going on there that needs to be taken care of. And if we don't experience that, then we're not going to be able to take care of that, and the appendix will burst, and unfortunately then we will die, right? So this is really important signal of pain. And you can really see the importance of pain when we see what happens when people don't experience pain. And this can occur if people have really severe diabetes and have nerve damage that results from that. And what can happen sometimes in these cases is people get what starts as a small wound on their foot, and because they don't feel that, it can get infected and get really exacerbated and can cause all kinds of problems for them. In an even more extreme case, people can be born with a genetic disorder called congenital insensitivity to pain, or CIP. Sometimes it's also called congenital analgesia, and analgesia just means lack of pain, right? So they're born with it. That's what congenital means, and it means that you don't experience any pain, right? So they can feel touch and sometimes temperature, but they don't experience pain. And usually it takes a little while for parents of these children to notice this, but not too long, right? It's not too long before the baby gets a diaper rash, or you notice that baby is not crying when it should be. And this can, as I said, it can cause all kinds of problems, especially when children are toddlers and they're still learning about how to interact with the world. And if they don't have the cues of pain to tell them, not to jump off something high because that hurts, or not to touch the stove, they can get injured a lot. But again, they don't feel that pain, but it doesn't mean that their body isn't being damaged. And so unfortunately, a lot of these children don't live into adulthood because of the injuries that they sustain. And there have been cases of these kids dying from a burst appendix and things like that, again, because they don't have not only the pain signals from external damage to the body, but also from internal damage and issues there. So very scary thing, but also a very fascinating thing if you're interested in studying pain. And so researchers work with a lot of these children to try to understand how pain pathways work, both to understand how to treat these children themselves and try to fix those pathways so that they do experience pain, but also to better understand how pain pathways work so we can apply this to treating pain in people who do experience a lot of pain, and how we can help them to cope with that and to be able to treat that. So there's a video that I'll have posted there in the links as well that talks more about CIP, and I think this video will make most sense after the next section where we talk about how nociception works, because it links in a lot of the work on how pain pathways work, because again, here we're seeing that they don't work. And so it's a breakdown of the typical nociception process. So we've already given a definition of pain, but I want to give you another one here. This one comes from Dr. Ronald Melzack, and you'll watch a video about him as well, a very famous Canadian, and really just a famous researcher overall. I can't think of anyone who's had more of an impact on the study of pain and really on medical science as a whole, and in a way, and in particular in linking physical sciences and psychology. And really, we see a great example here of the biopsychosocial model of seeing that all of these factors are relevant in pain. So Dr. Ronald Melzack's definition of pain is that it's a personal, subjective experience that's influenced by cultural learning, the meaning of the situation, the attention paid to the situation, and other psychological variables. Pain that does not arise from physical injury is no less real than pain that does. And so, again, you're going to watch a video about Ronald Melzack, but in that he talks about really how he got interested in the study of pain, and it comes from a whole history of how we've thought about pain. And so really before him and before some other key early players in pain research, we had the assumption that pain was in direct relationship to the extent of bodily damage, right? You should experience more pain for a larger injury. But of course, it doesn't take long working with people who have been injured to realize that this is not really the case, right? People can have a really extreme injury. They can have their leg blown off by a landmine, and they may not initially experience pain, right? We know that people go into shock and may not show signs of experiencing pain right away. Certainly, this hurts a lot later. But pain is not a simple one-to-one relation between the extent of bodily damage and the experience of pain, right? In that same example with someone losing their limb, right? They might not experience a lot of pain right away, but then they can experience a lot of pain later, even after that amputation has healed and there's no more wound there, right? There's no more leg left to be injured, and yet they can still experience pain in that leg. And so really all of these questions brought him an interest in studying pain, and he's become really the most famous researcher on pain and has developed the McGill Pain Questionnaire, which is used throughout the world and is the number one used measure of pain in research. And so just really important in this definition of pain is that pain is really about the experience of pain, right? So it matters these individual and social and cultural factors, right? So we're seeing that biological, psychological, and social piece going on here, right? And certainly there's a physiology to pain, and we're going to be talking about about that in this lecture. But pain is also impacted by these other factors, right? Pain is individualized and subjective, right? Individuals differ in their sensitivity to pain for both biological as well as psychological reasons, right? Some people have more active nociceptors. They have a lower threshold for signaling that there's pain in the body, and that can be due to biological differences, but also for psychological reasons, right? Based on past experiences of certain types of pain, people differ in their sensitivity to pain, right? So some people who have experienced chronic pain for a long time get really good at coping with that. And it's not that they don't experience pain anymore, but their tolerance of that might be much greater. And so they have just different levels of sensitivity to pain and would experience the same level of injury as someone else in a different way. Other psychological experience with pain can make people more sensitive to pain, or past experiences can impact that. Pain is also situational, right? So whether a given stimulus will cause pain can depend a lot on the situation, right? We hear a lot about people playing through the pain in a sporting event, right? And so the same kind of twisted ankle in that might be not felt in the same way as if it was twisted in a different context. And this has to do, of course, with endorphins that are released and adrenaline, right? And so there's a physiological part of that, but there's also a situational impact on our experience of pain from that as well, right? We might be, because of that competitive situation, more motivated to push through that pain, and so have a different experience of that in that context. You can also think about the situational influence of this, right? The same level of being hit or scratched in one context might be very painful, and in another context might be very pleasurable, right? Depending on what you're attributing that experience to, right? Is someone trying to hurt you, or is this something that you're consenting to and want to be a part of, right? So that a situation can really shift how you experience that pain. There's cultural influence as well, right? It's not that cultures lead people to necessarily have differences in how their brain reacts to pain, but people can certainly differ in the norms of how you express pain and the behaviors that go along with pain, right? So some cultures really emphasize stoicism and not showing pain, and others emphasize more of an expressivity around pain and that it's okay to show those things. And certainly that also varies within cultures and by genders too, right? So again, the point here being that pain, as much as it has a physiological mechanisms that underlie it, is influenced by these social and psychological factors as well. And so again, it's Melzack who really brought this idea to the table, really bringing pain into the health psychology area, right, where we're looking at it through the biopsychosocial model. How do we measure pain, right? There's many different ways we can do this. I already mentioned that the most commonly used in research, and particularly studies of people with chronic pain, is the McGill pain questionnaire. But there's also other ways that we try to assess pain, right? That's a relatively long questionnaire that needs to be filled out with a number of items. But let's say you've got someone coming into the ER with an injury and you want to get a quick assessment of their level of pain, right? So often we use verbal reports and simple self-report scales, right? So we might just ask somebody about their experience of pain, but that can be really hard to describe. People might describe that in different ways, so that doesn't usually work particularly well, especially if you're trying to triage quickly and make decisions about who to treat. So we often use these simple self-report scales, right? You're asked to rate your pain on a scale from 0 to 10 or 1 to 10, depending on how they phrase it. For small children, they might use faces like this, right? If you're in no pain to severe or very worst possible pain. And so these, while they certainly work in the sense that people do have a subjective experience of their pain and they can rate that there, they're not always the most accurate in terms of comparing different people, right? People might use these scales in very different ways. How you use it might depend on the worst pain you have experienced previously, right? Someone who's been through a lot of pain already might rate the same type and level of pain much lower than someone who has not had those experiences of pain before and so sees this as the worst possible pain. And so really, I think this is a great measure of how cooperative and how quiet people are likely to be in the waiting room in the ER on this measure. But it does really work in terms of looking at an individual themselves and comparing to their own level of pain, right? If they're typically a 1 to a 3 on any given day, and then today they're, a 9, that really means something. But comparing two individuals' 9s doesn't necessarily work very well. Just as kind of a funny example, just a couple years ago now, right before we were about to go on our honeymoon, Dr. Metz was trying to close an X-Acto knife and sliced her thumb open real nice. And, we went to the ER. It was our first time in the ER in Canada. I was really, really impressed overall with just everything and how quick everything went. But we got in there and we had a young doctor, and he asked Dr. Metz to rate her pain on a scale from 0 to 10, 0 being no pain, 10 being the worst pain you can imagine. And she said a 3. And I said, excuse me, I'm gonna interrupt here. I happen to teach health psychology, and I know she's saying a 3, but she did pass out twice in the cab on the way here, and so I think you should take that into account when taking in her rating of a 3. I think it's much higher than that. This is the most pain I have seen her in a long time. And so they did take that into account and got us in pretty quickly. And I asked her afterward, why did you say that? Why did you say a 3? They're not going to help you if you say a 3. And she said, well, he said 10 being the worst pain I can imagine. And I can imagine a lot of pain. It could definitely be worse. And I think that, that really speaks to how individual differences impact their subjective experience of pain and how they would rate that. So again, these work really well for looking within an individual, but not well at comparing to individuals, right? If I had gone in with the same injury, I would likely have said this was like an 8 or a 9. And so these again work well for getting your experience of pain, but doesn't necessarily reflect the extent of the injury. We talked about the McGill pain questionnaire, and so really what this brings to the table is that it assesses a number of qualities of the pain. So it asks about the intensity of the pain, which is really what this simple self-report scale gets at, but also the character of that pain, right? Is it throbbing? Is it burning? Is it constant? Is it intermittent? And it also locates that pain in the body. And so this, while it's more difficult to interpret very quickly, right, it gives you a lot more information about people's pain. And so this is a really an excellent scale for getting a more comprehensive picture of a pain profile. This is really useful in trying to diagnose the source of that pain, because we can identify that certain types of diseases and disorders lead to certain profiles of pain in different people. And so that's the character of pain, right? We can use these different words to talk about it. We can say we have a burning sensation, that we have a throbbing or aching. So this is just to indicate that, right, that the people naturally use these kind of words. And what Ronald Melzack did was to really formalize this, right, going around to patients in different types of pain scenarios and asking them, what does that feel like? And then using that as a way to formalize the different experiences of pain that people have. Just for fun here, I put a little comic that says, I get a stabbing pain in my eye whenever I have a cup of tea, and the nurse says, try taking the spoon out first. Took me a minute the first time, but it's because he's got the spoon in the tea and he drinks it and it pokes him in the eye. So we talked about verbal reports, simple self-report scales, the McGill pain questionnaire, and then there's also other types of multidimensional pain inventories. And I believe I have a picture of this on the next slide. Yes, and these look at all kinds of different aspects of pain, from the characteristics of pain and its intensity, like the McGill questionnaire, but also include how much that pain interferes with daily activities, as well as the responses of others, right? It looks at social support, right? You can really see a social factor in this. And so often they ask about spouses. If there's not a spouse, they ask about a close other, and how they are responding to your pain. And often in these multidimensional pain inventories, they'll also have a spouse or a close other fill out a scale about you and how you seem to be coping with that pain. And so this really gives a picture not just of the experience of pain, right, but how people are functioning with that pain and how much it's interfering with their lives. And so this gives a really good picture of that, and is mostly used in chronic pain scenarios where the pain is going on for a long time and may not be able to be directly treated, right? We try to help people cope with it. We try to minimize that pain, but we can't fully remove the source of that pain. For example, with arthritis or things like that, right? We can treat it, but we can't cure that. And so we might want to be looking at really how are people functioning in their lives and trying to intervene in those places, right? We can intervene at the level of social support. We can intervene at the level of control in people's lives. We can intervene and try to help people with their mood, but it's really difficult to intervene more than we already do in terms of how we try to physiologically treat certain pain syndromes. Can also engage in behavioral assessment. So another way we can look at pain is by looking at people's pain behaviors, right? What are they doing with their face? Are they saying anything? Are they saying, ow, that really hurts? Are they screaming? Is their face twisted up? Are there distortions in their posture or their gait, right? If someone's limping, that can often be a sign of pain. Again, not always. Some people have a limp that's not painful, but especially if someone doesn't normally limp and they're starting to limp or to be kind of hunched over, that can often be an indication of pain. negative affect, right? So the multidimensional pain inventories look at this as well. But when people are in pain, right, it usually puts you in a bad mood, right? It makes you grumpy, and of course it does, right? It's psychologically taxing. It's physiologically taxing. It's really grating to be in pain, and it takes up attentional resources that then you can't devote to, regulating your emotions in the same way. Also, they can look at whether people are avoiding activities. You see this also in those multidimensional pain inventories about people's, a level of functioning in their life, but you can also look at this directly through their behavior, right? If someone usually is, walking often up and down the stairs to get things, and you find that they're not really moving off the couch much anymore, or they're not walking the dog as much as they used to, this could be a sign that they're in pain as well. Right? So we can look at these behavioral assessments. There's also an interest in looking at physiological measures, right? So we might hook people up to equipment to assess their muscle tension, right? Often when we're in pain, we might clench up and tense as a response to that pain. We might look at people's skin temperature, right? So pain activates the sympathetic nervous system, and so when that happens, right, we're going to increase our energy output, and so our skin temperature is going to rise, and so we could measure that. We can also look at heart rate, right? That also goes up when the sympathetic nervous system is activated, and so all of these show relation to pain, but it's not a one-to-one measure, right? These are really measures of sympathetic nervous system activation, and that could be activated for different reasons as well. And also, again, people who, for example, have experienced chronic pain for a long time, right? They might get very used to that, and their system no longer activates in the same way, but they're still experiencing that pain, right? They may not have that spike in muscle tension or skin temperature anymore, but the pain is still there, right? And so this can work well for looking at differences within an individual in response to acute pain stimuli. Like if you're doing something in a study and I zap you, and I can look how much you tense up after this zap versus that zap, but looking at across individuals with these measures, you can't really easily compare individuals to one another with this. There's no reliable physiological measure for amount of pain, right? We can more and more, we're seeing people look at this in the brain and the amount of activation in the brain. But this is not this is not a clear one-to-one. There's all kinds of factors that can influence that. So physiological measures can give us an idea of the extent of pain, particularly within an individual, but not necessarily between individuals. Just to give a little bit more formal definitions of some words I've been using of acute pain versus chronic pain, right? So acute pain is normally from it's brief, right? That's what acute means. It lasts for a short time. It should say it is brief, and it's normally from something like a cut or a smaller burn or an injury. And so again, these are really adaptive because they signal to a person to avoid further injury, right? So these are these sort of short-lived injuries that occur, but chronic pain is the type of pain that endures over months or years. And there's usually no adaptive reason or biological benefit in this place, right? It could be due to nerve damage that's causing chronic pain, right? And there's no real benefit to that, right? It's not helping you in any way to avoid further injury. Other types of chronic pain, right, can be from like an injury that hasn't healed well, and so now it's continuing to cause pain, and you no longer are needing to have it heal, right? It's already healed, but it's not correct anymore, and so it's causing you enduring pain because of that. There's also pre-chronic pain, and that occurs in sort of the space between acute pain and chronic pain, right? And this could be something like you twist an ankle, and that lasts for a while, right? It's kind of more than acute, but it doesn't necessarily endure over months or years, but it could, right? So it could lead to chronic pain, or it could heal up nicely, and you could be good to go. So we might put that in the pre-chronic pain category. There's also chronic recurrent pain, and sometimes we include this within our definition of chronic pain. But importantly, right, so even if you're not all chronic pain occurs continuously all the time, right? It can often cycle in episodes where you have a lot of pain and then sometimes where you have no pain or much less pain, right? And this can particularly happen with autoimmune disorders, which we're going to talk about in our next lecture on chronic illnesses. But often people have what we call flare-ups, right, where they have a lot of pain and symptoms, and then they can also have periods where that disease is well managed and there's less pain. So it could be chronic recurrent pain like that, or also you might know people who have chronic recurrent back pain. They might be good for a while and then they tweak their back again and it's back to another episode where they're on the couch for a long time and then they get better for a while and then they might tweak their back again and have more pain, right? So that would be an example of chronic recurrent pain. And again, that's a subtype of overall chronic pain. So that's what I wanted to say for the definitions and measurement of pain. And so in the next section, we'll return and talk more about the physiology of pain, right? I've already mentioned that we're going to talk about nociception, right? That's the physiological mechanism that underlies the perception of pain, or that is the physiological perception of pain. And so that's what we'll be talking about in this section.